And we're live.
Hello all, and welcome to the first event for Taking the Call, a national conference exploring innovative community responder models. This event is presented by the Council State Government's Justice Center in partnership with the University of Cincinnati and with the support of the Bureau of Justice Assistance. Thank you to all of you who are with us today, and thank you to our distinguished panelists. My name is Aisha Delaney-Brumsey, and I'm the Director of the Behavioral Health Division at the Council State Government's Justice Center. We are a nonprofit, nonpartisan organization working with government leaders in all 50 states to support improvements to justice system across the country. For all of you who are here with us, we invite you to join the conversation. We've held time at the end to answer questions, and many of you have already submitted questions in advance, so thank you for that. If you do have questions during the event, please submit those through the chat box or on Twitter by using the hashtag #TakingTheCall. We're here today to explore a vital question, one that we've heard over and over from people across the country. How can we make crucial improvements to our 911 and crisis response systems to support the needs of people in crisis, rebuild trust with communities, and protect public safety? Often, law enforcement are tapped to serve as the first or only response to address complex needs associated with trauma, poverty, and health conditions. These can be challenging situations where officers may not be the best positioned to respond and may have few options other than taking someone to the emergency department or to jail. And for the person, these interactions can be difficult, even traumatic or tragic. Conversations with our partners underscore that law enforcement and community members agree that the status quo is not working for anyone, and many jurisdictions have identified community responder programs as part of how we begin to shift that status quo. Community responder program is a broad term, and the exact name and structure of these interventions vary from community to community. But most community responder programs meet two general criteria. First, they are mobile units that are staffed by behavioral health professionals, such as social workers, peers, or community health workers. Sometimes those behavioral health staff are paired with a physical health professional, such as a paramedic or emergency medical technician. Second, those mobile units are deployed as first responders to 911 calls and sometimes to other urgent calls for service in order to reduce unnecessary law enforcement contact and improve connections to needed supports. They often provide services for a range of needs, such as when someone is experiencing a behavioral health crisis, is in need of emergency housing, or when neighbors are having a dispute, and much more. After speaking with programs across the country, some themes have started to emerge about how they function and what is critical to their success. First, they often work best when they are built into a comprehensive system of community supports. So that after they respond to that initial call and provide immediate care, they can also connect people to housing, treatment, benefits, employment, longer-term supports that can bolster a person's well-being far into the future. And second, while community responder programs are rightfully focused on how they best meet the needs of the person directly in front of them, many are also thinking about how they can help build systems that advance justice, support human dignity, and promote equity. Systems that center and respond to the needs of some of the most marginalized communities, people of color, people with behavioral health needs, which can ultimately improve well-being for all. Many community responder programs operating today are relatively new. However, the concept has been around since at least 1989, when the CAHOOTS program was launched in Eugene, Oregon. More recently, communities across the US, from Atlanta, Austin, San Francisco, Portland, Rochester, and many more, including folks who are in this audience right now, have built their own community responder programs to fit their local needs. Today, you'll hear from representatives from two of those programs, the Denver Star program and the Olympia Crew program. They're well positioned to tell you about how their programs function and what are some of the initial successes and challenges. We have a great conversation lined up for you today. We will explore how variations in community responder models, what it takes to create an effective program, how they fit into a comprehensive system of care, and discuss some open questions about how these interventions can be effective components of local crisis response systems. But before we dive into today's discussion, I want to emphasize that this is just a first touch point in a series of events and ongoing work that will include our 2-day Taking the Call virtual conference from October 20th to 21st. We are really in an exciting moment when communities across the country are seeking to innovate and come together across law enforcement and health to collaborate with community activists, people with lived experience, and others to design systems that support people in some of the hardest moments of their lives. Through these events, we will foster dialogue across communities so they can learn from one another, from experts in the field, and work together to drive meaningful change. Registration for the October convening opens today, so please click the link in the chat to hold your spot and to receive notifications about upcoming events and resources. Thank you. And so now I'm thrilled and privileged to introduce the first of our two very special guests, Chief Murphy Paul of the Baton Rouge Police Department. Throughout his career, Chief Paul has served on multiple boards and commissions, including the Louisiana Governor's Drug Policy Board and the High Intensity Drug Trafficking Area, or HIDTA Executive Board. Prior to his work leading the Baton Rouge Police Department, he served as a deputy superintendent with the Louisiana State Police. Chief Paul, you've done incredible work in Baton Rouge to support improvements to local crisis systems. Can you tell us, can I turn to you to talk about why, from your perspective as a law enforcement leader, this type of work is important and what it means for communities like Baton Rouge and others across the country?
Yes, first, thank you for the opportunity to speak. You know, when we talk about crime and mental health, you know, one of the things that we understand is that crime is a social economic issue. But our reality today in America is that the COVID-19 pandemic and current events have exacerbated the pre-existing trauma that's happening in communities all across America. You know, the interruption of our normalcy, the economic hardship, the interference in our education system and services and counseling, from substance abuse, mental health, interruption in our faith-based system, all of that has created stress and anxiety and the mental health crisis that was already existing in our country. So as law enforcement leaders, you know, we have to no longer engage in normal business and in the belief that a punitive criminal justice response is good policing in America today, because it's not. You know, it's not the most effective evidence-based way to address mental illness. So the preservation of human life and officer safety has to be incorporated in every part of our training and all parts of our policy. And when we look at recent events in America that highlight the current state of policing to serve as critical opportunities of improving the policing strategies for mental health care response. And it also rebuilds trust between law enforcement and the communities, and even more so in disinvested communities and communities of color. So when we examine use of force, right, and incidents in mental health calls for services, what we see that there are so many opportunities for intervention and also de-escalation. But we have to be honest about the conversations, just like we're having today, right, about how we can decriminalize mental illness, but also expand those conversations into substance abuse so that we can improve not only officer safety, but public safety as well. And in law enforcement, I know we train our police officers in CIT training and how to respond to individuals who are experiencing a crisis, but we have to develop alternative responder models and systems that keep mental health from becoming a criminal justice entry point. And that police officers should not always be the default first responders when individuals are experiencing a mental health crisis, that we should have mental health professionals who are best trained and prepared to address those type of calls for services. I think we can all agree that as a law enforcement leader, that we should always want to prevent crime rather than to react to it. And what we created here is a mental health crisis stabilization center that helps us do that. And it provides the appropriate care to individuals who are experiencing a mental health crisis. And we're doing that through self-admitting through admitting by caregivers, but also by our first responders who are responding to 911 calls. So let me just highlight what's going on here in Baton Rouge, because I'm excited about this, and we're already seeing wins in this short period of time. You know, when we got together as leaders, we understood that mental health is a community issue. It's not a policing issue. And so what we did is in Baton Rouge, we voted yes for mental health. So we got all our stakeholders together, our mayor's office, our law enforcement, district attorney's office, our business community, our healthcare professionals, and we began to campaign for this back in 2017, leading up into 18, so that we can establish the Mental Health Crisis Stabilization Center here in Baton Rouge. And I can tell you that we were united in that effort from day one. And that was the key, right? Getting out there in the community, getting the support, education and awareness, and being united in this effort to address community, address mental health as a community issue, not just a policing issue. So we came up with about a 1.5 millage property tax that's estimated. It costs about $1.50 per month for the average homeowner, whose homes are valued at about $200,000. But that tax generates about $6 million annually for 10 years. And it's estimated that it's going to save the Baton Rouge community about $55 million over the lifespan of that tax. So we started the Bridge Center for Hope right around February of this year. And what it has done is it keeps our friends, our colleagues, our loved ones out of jail and out of the emergency room, and it connects them to long-term care that they need to break out of this cycle that we've been experiencing for far too long in our community. And, you know, when you look at what's happening in law enforcement today and the challenges, you know, in the first 3 months, the Bridge Center for Hope, we had around 216 independently individuals who were experiencing a mental health crisis, who were actually came in through a family member, through a care. But we had 209 first responder admittance into the center, where our police officers responded to a call and ended up dropping someone off. That time is under 4 minutes. Right now, we're averaging about 3.5 minutes when our police officer pulls up, drops someone off at the Bridge Center for Hope, and now he or she is able to go back out there and patrol. We did not have that available. So we are already, prior to Bridge Center for Hope, so we're already experiencing cost savings. We're seeing decreases in response time to calls for services, because we're redirecting those resources now, where in the past they would sit at the hospital or in jail until they're able to leave. And I can tell you, from a manpower and redistributing those resources to be more proactive in our efforts, it is really refreshing, because we are already in the law enforcement community experiencing challenges with recruiting because of what's happening in America today, as well as retirements. So to have the ability to redirect those resources to address violent crime and that small 6% of individuals who are causing the violent crime in our communities, I just appreciate having a Bridge Center for Help. And I tell you, it's important to recognize and understand how getting the community support at the beginning. You know, we were told that tax would not pass, a new tax wouldn't pass, but the community heard us loud and clear. And I think in part it's because the community understands that all of our families are impacted in some type of way by mental health. So having that right campaign, having the right community stakeholders at the table at the beginning stages, and then being united in that effort to rethink how we respond to mental health is so important, especially in policing today, because social media has made the world so small.
Thank you, Chief Paul. Your remarks were really insightful. And also thank you just for the work that you're doing and for highlighting the real efforts in Baton Rouge. We appreciate you taking that time. So now I'd like to turn to Ms. Karis Myrick. Ms. Myrick is the co-director of the Mental Health Strategic Impact Initiative, or S2I, which aims to advance the transformation of mental health services. She serves on the board of the National Association of Peer Specialists and was previously the chief of peer and allied health professionals for the Los Angeles County Department of Mental Health and director of the Office of Consumer Affairs for Samsa Center for Mental Health Services. Paris, you spent a great deal of your career working to improve the supports that communities provide for people with mental health and substance use conditions. You have worked to ensure that social services are not just designed with the people they are meant to serve in mind, but also are designed and operated by people with that lived experience. Could you speak to what you see as some of the key crisis system response innovations and what you see in particular as the role for people with lived experience in shaping community responder programs?
Sure. So first of all, thank you so much for inviting me in to come and give a few remarks. And, first I want to let people know that I'm, located in Los Angeles, California, which is the unceded land of the Tongva and Chumash people who have been stewards of this land for generations. And if you can't see me, I am African American. I'm also Native American. So I do speak a lot from that experience of being a person of color and also being a person who has been given a diagnosis of a mental health condition and has been involved in crisis system response, different types. So, I think that's why I've been invested in the work. But I, along with others who do this advocacy on a system design or redesign work, really just ask a simple question. When somebody has a heart attack or a stroke, or maybe they're having crisis to dementia, who responds? Generally, it's ambulance and EMTs. They tend to be the first responders. Yet for mental health, which we say is like any other health condition, it isn't treated with the same parity. And the jurisdictional policies result in law enforcement being the default responders in mental health crisis. So I've been working, for example, on a couple of different reports. Some of them involve people with lived experience, and I was involved in one of them, which is the Group for the Advancement of Psychiatry's work, which laid out a roadmap to the ideal crisis system. That was the name of the report, in which it says that every person should get the right response in the right place every time. And when I couple that with other work that we've done, which is on the front end project, From Harm to Health, centering race equity and lived experience in mental health crisis response, then we start to unpack what does it mean for people of color with mental health conditions who are in crisis to define what is right for the response as well as the place. It has to be informed by people of color with lived experience. And because we want to be able to help think through what is, again, sort of right. It has that sort of pejorative kind of sense to it. So one of the quotes from some of the folks in the Harm to Health report said, a crisis happens when the police show up as the responder. So that's certainly what we wouldn't want. That for people of color, specifically Black and brown folks, police interactions have yielded deadly outcomes, and the disparities are also most glaring for those in mental health crisis, in which there's a tenfold difference from the general population for people of color, with the result being death. So we all agree that we need to do things differently to ensure safety for all, of course. And for people with mental health conditions, that approaches are health approaches, not just public safety approaches. They should be approaches that meet people where they are, identifying the issue that needs to be addressed, partnering to meet the immediate need that honors the dignity of the person, their cultural preferences, and helps with the path forward to recovery and flourishing. So for me and many like me, meeting a peer supporter, especially one who looked like me, and having access to supports in ways that I could enter in, kind of like dipping my toe in the water, is how I and others describe how peer support has helped. Evidence has shown that people can move from homelessness to being housed, unemployed or on disability to being employed or having more meaning and purpose in their life, and from isolation to being connected. So peer support is proven to help peers in their recovery, and it is also cost effective and particularly valuable in rural and communities of color. For peer support specialists are also invaluable on mobile crisis teams, and it is one way to remove police from the mobile crisis equation. So one of the right places that we heard from peers is also peer-run respites, which provide a place for people to recover from crisis that is safe and supportive. During crisis, we are at our most vulnerable. And it's when, like, we think of the 4 Ps, people, place, purpose, and I'll add one more, power, which is our autonomy, is really most disruptive. So this is a critical time to build that trust through compassion and dignity and facilitate connections back to people, our meaning and purpose in life, and to maximize our choice and autonomy as much as possible. And one of the ways that, we think about doing this in the role of peers is, yes, in delivering services, but we also want peers to be, and people with lived experience to be part of the redesigning, meaning, we're working now very hard at the national level and at states and localities, for example, on the new 988 number. And I ask myself, why am I sometimes the only person of color and the only person with lived experience in the room around designing these systems? These systems are meant for us as the recipients. So how is it that people know what would be most helpful from the recipient's point of view? So having peers as part of the conversation, a part of the design, the delivery, the evaluation, the implementation is really critical. And then for peers and peer supporters who are trained folks to provide support to others who are in a mental health crisis or have substance use disorders, having peers on crisis lines, text lines. They also can train an entire team, not just a peer team, but an entire team on responding to crisis. Peers are doing evaluation and research. They're involved in outreach and engagement, especially with for folks who are most vulnerable, especially those experiencing homelessness, are involved in criminal justice interactions, and are involved on very innovative alternatives to incarceration programs. So there are a myriad of ways in which people with lived experience can be involved, especially those who are people of color. And I I'm going to put a challenge to folks. It's just the best way I know how to do it, which is to ensure that when you are putting together your advocacy for legislation, when you are doing your community feedback groups, when you are developing your crisis system response, when you are looking at legislation related to 988, and 988 is just a number, where are people going to go, if indeed people even need to go somewhere? Because sometimes what we heard too is that people are calling because they have actually a health issue and they don't know where to go. But because they have a mental health issue, it's the police who respond. People are lonely, especially now during the pandemic when social isolation is at its highest. Who should be the responder there? And helping people there. But in order to take that information and have it really be implemented in ways that people of color with mental health conditions and who are mental health crisis can respond, we have to be a part of developing that system and designing that system along with others. So that is my plea to everyone and my challenge to ensure that you look around the table, who's missing? Hopefully not us. Thank you.
Karis, thank you so much. Thank you. Those were powerful reflections. Thank you for your work in this space and for your advocacy. I just want to say a really heartfelt thank you to both you and to Chief Paul for setting the stage for the conversation with our panelists. So now, please join me in welcoming our panelists and our moderator, Dr. Robin Engel. Dr. Engel is a professor of criminal justice at the University of Cincinnati, where she teaches in the areas of policing and criminal justice. She is also the director of the IACP and the University of Cincinnati Center for Police Research and Policy. For the past 20 years, she has engaged in research and evaluation in the field of criminal justice and worked directly with practitioners to implement evidence-based strategies and best practices. Dr. Engel, thank you so much for being here and for facilitating. Can I turn to you to introduce the panelists?
Yes, that'd be great. Thank you so much, Aisha, and also to our friends and colleagues at the Council of State Governments for hosting this event. It's such an important topic, as we all know. And I'd also like to thank Chief Paul and Director Myrick, for your insightful comments, both from a law enforcement and professional perspective, but also from those lived experiences. I'm very privileged today to further this important conversation. In order to do that, I'm going to turn to 4 individuals with various perspectives and positions in the field. Each of these amazing professionals have unique and important experiences to share regarding the implementation and support of community responder models that are designed to effectively address persons in crisis. So I'm honored today to be joined first by Director Kristen Mahoney. Director Mahoney, it's so wonderful to have you. She's the acting director of the Bureau of Justice Assistance within the Office of Justice Programs. Director Mahoney has comprehensive and practical experience creating criminal justice policies, programming, and technical assistance that aids state, local, and tribal communities. In 2016, Director Mahoney was recognized for her work in developing the Violence Reduction Network, now we all know as National Public Safety Partnerships, or the PSP, and was also awarded the Presidential Rank Award of Meritorious Executive by President Barack Obama. Kristen's no stranger to those of us that work in the law enforcement field, so thank you so much for joining us today. We also have with us Dr. Anita Everett. Dr. Everett is the director of the Center for Mental Health Services with Substance Abuse and Mental Health Services Agencies, better known as Samsa. She provides executive leadership for federal efforts to improve the nation's mental health services system. Dr. Everett has served on National Institute for Drug Abuse, the National Advisory Council, and was also the president of the Maryland Psychiatric Society and the American Association of Community Psychiatrists. Also, not a stranger to those of us who have been working in the field. We are so grateful to have you and your perspectives brought to us today. And then I'd also like to introduce 2 of our other panelists from the field. First, we have Miss Ann Larson. Miss Larson is the Outreach Services Coordinator at the Olympia, Washington Police Department. In Olympia, she manages the Crisis Response Unit and the Familiar Faces program. Ann strongly believes in the power of employing peers in her programs to create supportive relationships based on trust and respect in an effort to increase empowerment, improve personal success, and build linkages to needed community resources. And we're so thrilled to have you and with your personal perspectives actually out there in the field implementing these programs. So we're looking forward to your comments. And then finally, we have Miss Carly Salon. Ms. Salon is the Program Director of Criminal Justice Services at the Mental Health Center of Denver. So she's representing the STAR program. Carly is licensed clinical social worker and a licensed addiction counselor. Most recently, she's helped develop and manage the Support Team Assisted Response, or STAR. This is a pilot program that's gotten a lot of press and interest lately across the country. Lots of people are asking about the STAR pilot program, which created a team of licensed social workers and paramedics who are responding to low-level, low-risk 911 calls in downtown Denver. Thank you so much, all of you, for being here today. I am so excited and appreciative and looking forward to the conversation. And so with that, I'm going to put Director Mahoney right now in the hot seat and take you first. I would like you to please share with us the role that you see that BJA will play as communities across the country are developing alternative responses to crisis.
Great. Thank you. Can you give me a thumbs up if you can hear me? That's great. Thanks. I've learned to ask for that during these Zoom calls. Good afternoon, everybody, and thank you for the introduction and for the opportunity to speak with you all today. I want to recognize Chief Paul, who's one of our public safety partnership chiefs. So that was really exciting to hear from them. And I also, I want to talk to you a little bit about my background when I was at the Baltimore Police Department, and one of my responsibilities was running the 911 call center and the dispatchers. And, I started there as a civilian grant writer and kind of wound my way through some different positions, but landed in as the Chief of Technical Services, and this is what I was responsible for. And I will tell you that there is no greater problem solver on the police team than the 911 call taker and the dispatcher. These individuals are the secret sauce to making communities safe and getting assistance to where it's needed. They know the police officers, they know the mental health experts, they know the community members. Half the time, I had instances where they all got married to one another. So, you know, I really like working in this area because I know how people really lean in. And speaking of leaning in, you know, I guess I think you should know that there's really no greater advocate for helping people get connected to the help that they need than President Joe Biden. He's committed to the efforts to show that allow mental health and substance abuse disorder experts and social workers, disability advocates to partner with police and de-escalate interaction with people that are with severe emotional distress. And we've long supported these types of collaborations because of the funding that the Hill has so generously provided to us, but also because of our personal commitment to working in this area. And so we're excited to be able to continue to champion these efforts. We've provided over $100 million since 2006 in the Justice and Mental Health Collaborative Program. We worked with over 568 sites. The work never is the same. When we started, though, we saw that it might have been the first time we ever saw such collaboration. And now we're amazed at the innovation that people are using, the technology people are using, things that we've learned just from this pandemic about how we can better collaborate and reach people through technology. It's really exciting. And we've been able to develop new resources for the field, focusing on police mental health collaboration. This includes our peer learning sites, which I really love, and I cannot advertise enough our peer learning sites. And I know I'm supposed to announce who they are. Am I supposed to announce that right now? Is this my cue, or is it later in the program? Is it okay for me to tell?
You're the director. You are welcome to do whatever you want.
Well, I don't ever want to go out of line. I want to be as collaborative as I can, but I do want to let you know these peer learning sites. People often poo-poo them and say, you know, I don't really understand. You know, so you've identified these sites as peer learning sites. What does that mean? What does that mean? That means that you come to us or you come to our partner CSG and you say, I'm having problems developing this particular policy or implementing this policy, or I can't seem to get along with my county health department, or the state's not giving us what we need, or, you know, just these things that you think are intractable problems. And we say, well, we have these learning sites that we can parachute you into. They want you to come there. They want you to take their policies and practices. They want you to be kleptocrats and take everything you can and bring it back to your bureaucracy and make it work. And CSG and and BJA provide funding for this. And cities sign up and say, we think we could be a learning site. And they are open for business. And they apply and we review their policies, we review their practices, we review that they follow all the important things within our justice and mental health portfolio, and then we anoint them to be learning sites. And what that means for the field is that the field has free transportation and lodging and training and technical assistance to go and see this as a team, to go and see it firsthand. So it's not just that one, you know, innovative voice in the room going, I think we should try this. You all go together and you all go see how it works. All the Debbie Downers get to see why it actually does work, you know, and ask those questions, and peer-to-peer learning is just so exciting. So, and they stay with you, right? So after you go and, you know, you might do some pre-calls and then you show up on scene and you're hosted and then you come home and they continue to work with you, and CSG continues to work with you, and it's a hallmark of this program. And so without further ado, I'd love to announce that Harris County, Texas, Bahar County Sheriff in Texas, Miami-Dade County, Florida, Yavapai County, Arizona. I'm so sorry. No one did phonetics for me on that one. And the Wichita, Kansas Police Department are our new learning sites. And I think that these new sites will join our existing sites to help you advance this work. And that is really our biggest contribution in addition to the general direct funding. So thank you, Rob.
Thank you, Director Mahoney. Let me just say, I'm really excited about those peer learning sites too. Not a Debbie Downer, but as a researcher, we really need to learn how to best implement. And we need to learn not just best practices, but also what doesn't work or what could be done better. And for these communities to open themselves up and to serve as models is really inspiring. So I'm really very excited about your announcement today. That's terrific. Now we're going to turn to Dr. Everett to see what's happening at Samsa. So Dr. Everett, in the last year, we've seen that Samsa has released new guidelines on developing robust crisis care continuums and also building on Samsa's long-term focus and funding commitments in crisis care. How do you see these new and enhanced partnerships and an increased involvement of community responders working within an ideal crisis system? What does that look like for you?
Great. Thank you very much, and I want to also thank my colleagues for inviting us to be part of this conversation. We're very honored by that. So what I wanted to talk about is three sort of categories of processes that Samsa is working on right now. The first of these has to do with creating that vision and thinking a little bit about how things could be rather than how they are. And in order to do that, we've created several documents that support that, which are going to be appearing in your links there. Our vision starts with the idea of the start point being a person in crisis, and what does a person in crisis need? We say they need one of three things. They need someone they can talk to. For those for whom that doesn't work, they may need someone who can respond, someone who can come on site, and or a place that they can go. A place that they can go that's equipped to assess, help stabilize the situation, and they may or may not need referral beyond that to a clinic setting that is able to be responsive. And so those three elements are sort of the elements that we focus on quite a bit. To build on that, one of the ways that we've started with that in our immediate focus is to develop out as far and as robustly as we can this 988 process. So Congress passed at the end of 2020 an act called the Crisis Mental Health Suicide Prevention Crisis Line. And it was an act that set aside the notion that, or the provision, or the requirement really, that by June of 2022, from any phone line or any cell phone in the United States, you will be able to dial 988, and speak with a mental health crisis, a trained individual that can provide an intervention in that way. So we're scurrying around quite a bit to fill out the office and create this national network that will work on that. There are a lot of details to be worked out with regards to how that's going to work, and in particular how that's going to interface with 911. And so I've heard, Director Mahoney, your experience, and don't be surprised if I call on you to sort of help us with that, because there's a lot of details that are going to be worked out. But we know, on a national level, we know that something on the order of 10% or so, in some areas more, calls that come to 911 actually could safely go to a 988 or sort of an alternative responder. So that is very important and something we're working on. A lot of this year for us will be working on strengthening the responsiveness of the line. The line will be built out of what currently is known as the National Suicide Prevention Lifeline, which is the 1-800-273-TALK line. That'll be gradually converting over to 988. And we will appreciate as much information to the general public as possible so that those increasingly people are aware that they can call 988 instead of trying to remember 1-800-273-TALK. The second thing that we've set in motion is state planning processes. And so by now we're in our first year of receiving a special grouping of funds that were attached to a thing that's called a mental health block grant. And what that's done for us, it's a small amount of money really in the scale of things, but it is large enough that every state now has submitted to us just in the last week or two a plan through which they're going to look at expanding their array of crisis services. And we're excited about this because we're asking that be a state planning process. We think everyone, that lives in a state ultimately should have access to anytime, anywhere, any place, someone they can talk with, someone who can respond, and or a place to go, like the center that Chief Paul demonstrated, which is really a brilliant example of these crisis receiving centers, which we'd like to see increasingly, more of. So the crisis set aside funding is our third sort of element that we've been working on. We're hoping that over time this will really help to stimulate and catalyze state planning, so that the states, are involved in the action. So if you live in a state, you should be able to contact your mental health authority and understand, or and especially if you're an advocate, to the point that Karis brought up about the value and the role of people with lived experience being active participants in these models. And we're going to hear a few more, I think, in a few minutes. The models frequently involve peer support specialists as a component of them because of the value that they bring to situations of human beings being in crisis related to a mental health reason. So those are our sort of three things: creating a vision that's approachable, building out 988, and then these crisis, the state planning process which we've set up now in every state. I want to thank you very much, and I'm looking forward to hearing from our other panelists that can tell us sort of what it's really like on the ground in the communities where these services have been developed. Thank you.
Great. Well, thank you, Dr. Everett. I'm really excited about that 988 crisis response as well, because we all know how 911 really revolutionized and changed public safety so dramatically. And so thinking through what this type of national response initiative could look like is really very exciting. I bet a little bit daunting thinking about all the details around it, but nonetheless, really exciting work. So thank you to you and to Director Mahoney from the federal level, really putting the support and the resources in place and directing them into the communities where the need is greatest. But let's talk directly, as you mentioned, to the field and find out what is happening in the field. What do these best practices look like? So first, let's turn to Olympia, Washington. So we're going to hear from Ann Larson. And Ann, you're working with the crisis responder unit, and actually you've set this up and are running it. Can you tell us a little bit about how the CRU team got started, the steps that you took to make sure that the program was meeting the needs of the people that you were planning to serve, and how are you working with other first responders?
Absolutely. So thank you all so much for having me here today. So my name is Ann Morrison, and I am a civilian embedded in the Olympia Police Department. And I was hired in 2018 to implement and create an alternative first response to law enforcement. So there are a few things that are coming up as themes that I'm hearing today, and one of them is funding. So in 2017, the citizens of Olympia passed what's called the Public Safety Levy. And that levy increased funds to our community court. It created funds for my position for this alternative response, and it boosted downtown walking patrol and other community policing initiatives. So I started this program on a backbone of community support. And then the chief at the time, retired Chief Ronnie Roberts, had come from Eugene, Oregon. So he had always known an alternative response. So I had chief support, I had law enforcement support, and I had community support in building this program. So one of the most important parts of having an alternative response is making sure that your law enforcement officers find it to be a useful tool. So one of the first things I did was do a law enforcement survey. And I asked our law enforcement officers, what are the hours that you're seeing folks in crisis? What is the nature of crisis? So in Olympia, we have an enormous houseless population. And so poverty is really one of the main reasons we're engaging with folks in our community. How would you like this team to be dispatched? So how do you want to get a hold of your crisis team? What does the team makeup look like? What are resources that folks in crisis need that this team should have on hand? So we did a big law enforcement survey. And then obviously, I'm a public servant and I only exist in the community that I serve. And so in Olympia, especially in our downtown core, we had a lot of friction between business owners and houseless individuals or individuals with behavioral health. And so I did a separate forum just for business owners so that they could tell me and they could tell the city what they would want in a crisis response unit or in a mobile response unit. And what I heard loud and clear at this time before 988 was they wanted to call 911. They didn't want to puzzle out what a crisis was, what a crisis wasn't. They didn't want to memorize a new number. They just wanted to call 911 and have an alternative response show up. Okay, great. So then we did, on the flip side, an advocate service provider forum where they could speak freely about their concerns. I'm embedded in the police department. There were concerns that we would run warrants or that we would be snitches. And they did not want to call 911. And so we're like, okay, great. The crew team carries cell phones. And so advocates and service providers in our community can call the crew team on their cell phones. The crew team will put out over the radio that they're en route to Union Gospel Mission or they're en route to Safe Place. But I didn't want to have any sort of barrier because I was locked in and checking off a box of like how to build a perfect crisis response unit and check those boxes. I really wanted to listen to our community because that's who we serve. So we're based off Cahoots, just like I think Carly's based off Cahoots as well. And I am open for business for any folks to come, especially as COVID starts to loosen up those restrictions and come and really see the magic happen. And I know you're going to hear some awesome magical things about Carly and her team, but I think one of the biggest things for us is everything we do is based on 4 principles. It's street outreach, harm reduction, trauma-informed care, and culturally competent care. And so because we do everything in the community, we do a lot of self-initiated calls. So for me, the best 911 call is the 911 call that's never made. So our team puts themselves into service, just like officers or just like firefighters, and they are either on the street or in their vans. So they'll see someone having some big behavior outside of a Starbucks. We get a lot of people missing shoes. We get a lot of people missing pants. Those calls, those folks generate calls for service. So if we see it, we respond to it. We're also identifiable. We say crisis response unit on the back, and we have a logo with a heart on it so that the community knows that someone is responding. We have peers in another program, and they wear hoodie sweatshirts and jeans, and they are responding and working with folks. But the crisis response unit, the community sees their van, the community sees them engaging folks, and they feel a sense of relief that, oh, I don't need to make that 911 call. I could go on and take up the next, kabillion hours. But one of the things I heard yesterday, and then I'll pass it over to Carly because her team is awesome and I can't wait to hear about them, is that the brain is an organ and it is a medical organ. It's a medical system that should be responding to folks with mental health and substance use. And law enforcement and criminal response is not the right response, but it is the response that we've been pushed into. And so I am just super excited about seeing where community responders go. I'm super excited to hire folks with former incarceration, and I could talk on and on about how that changes the culture on both sides of the badge. But I'm just super excited about the future and where alternative first response is going.
Well, thank you so much, Anne. Your passion just shows through. You can see just how dedicated you are to the work. And I love that you are willing to take on visitors, another peer site, if you will, to come and visit and to see for yourself exactly what's working in their community. That's really great. Thank you for that offer. So we are going to turn now to Denver, to the STAR program, and to Carly Salon with the Denver STAR program. Can you tell us a little bit about how the STAR program operates and also the goals of the program? We heard that it's based on the Cahoots model, so I'd like to hear a little bit more about your experiences as well.
Yeah, absolutely. Thank you. So the STAR program, Support Team Assisted Response, is a pilot program that's been running in downtown Denver since June of 2020. And it's a partnership between the Mental Health Center of Denver and Denver Health. And it creates a team of licensed social workers and paramedics that respond to low acuity 911 calls coming in through the dispatch system. So we respond to things like welfare checks, we provide transport to shelters, and we respond to behavioral crisis that doesn't, that's low risk. And we have responded to over 1,200 calls since we started. And one of the most important factors in being able to stand up a program like this was kind of getting everybody at the table to come together and sort of figure out how a program like this could reflect the Denver community and really serve the needs of our citizens here. So we engaged a pretty large community work group that was made up of different stakeholders throughout the city, Harm Reduction Action Centers, Servicios de la Raza, other service providers, and also a number of people with lived experience, either themselves or who have children who deal with severe and persistent mental illness. So that group was really integral in shaping this program and helping us stand this pilot program up. We worked very closely with the Denver Police Department while developing this program. So since 2016, we've had a co-responder program here in Denver that pairs a licensed mental health clinician with a Denver police officer. And we've had a long-standing great relationship with DPD. They're really invested in programs like this and see the benefit of having clinicians respond to these calls that don't really have a law enforcement nexus. And when police officers may not be the appropriate response for someone who needs a ride to a shelter or who's in behavioral health crisis. So through many of these calls that we've run since launching in June of last year, we've been able to kind of reroute the people from the ER being kind of the catch-all for folks and not always being the right level of care for someone who, could be better connected to community resources or an ongoing treatment team. And also, just allow police officers to focus on police work and law enforcement calls and sort of use it as a force multiplier in that way, while the STAR team takes on those calls that are more public health and resource in nature. So for example, we had a gentleman in the summer of last year who was, someone called 911 because he was in our downtown area with a broken wheelchair and looked like he was having a tough time and wasn't able to get around easily. So STAR went out and contacted him and spoke with him for a little bit, and his wheelchair was in fact broken. He wasn't able to move from that spot. And he really just said, I'm a veteran and I need to be reconnected with the VA. I've sort of fallen out of treatment. I haven't been in contact with my treatment team there, my case manager, and I really just need to get in touch with them. So I come from a case management background. I have a really good contact at the VA who I call on all the time, who sort of helps me and provides me with really helpful information. And I gave him a call and I said, hey, I have this gentleman here, and sort of explained the situation. And he said, oh my goodness, I've been looking for him for about 3 months. We haven't been able to find him, and he has an apartment waiting for him that he can move into, and we just, haven't known where he is. And he said, can you transport him up to the VA Medical Center in Aurora, and we can get him medically cleared and address his mental health and physical health needs, and we'll reconnect him to his housing case manager, and we'll, kind of take it from there. And that's exactly what we did. We drove him up to the VA, and that gentleman was reconnected to those ongoing community supports that keep him healthy and well and keep him off the 911 radar. So that's kind of just an example of the types of calls we're running on STAR.
That's great. Thank you so much, especially for that personal experience and the involvement. I'm interested because, as you mentioned, Denver for many years had the co-responder model. And of course, we know there are so many different responder models that are innovative and interesting and working in different communities. But to move from a co-responder model to now embrace a community responder model, I'd love to hear a little bit more just about that. If you have just a moment to talk about, are these two models in competition, or are they working together collaboratively, or has one just surpassed the other?
Yeah, so we have both programs existing simultaneously. They definitely collaborate. We have our co-responders who respond alongside the police to high acuity calls where there may be a risk element. We still want clinicians showing up with officers when there is a need for officers on that scene. But what we kind of learned running that co-responder program since 2016 was that a lot of the calls coming through the system didn't require an officer at all, but that's who was sort of tasked to respond to these calls just for sort of due to lack of a better option. So in Denver, we've really worked along with the police department to create response options and really focus on sending the right response when someone is in crisis or needs assistance in Denver.
Great. And what have you learned so far about the results of your effort?
Yeah, we've learned so much in coming up on a year of running this pilot program and really looking forward to expansion. So, we ran a 6-month evaluation back in January that ran all of our data. And one of the most important things is really constructing a good decision tree for your dispatchers to use to route the calls to the appropriate team, right? So does it require an officer? Does it require a co-responder, or is it STAR appropriate? And the Eugene, Oregon Dispatch Center was so helpful in assisting Denver with creating a decision tree that worked for our city. And in those, over 1,200 calls that we've run since last year, we haven't required police backup on any of those calls. So I think that really shows that we're making it to the right calls, and that STAR is the appropriate response to the calls that we've been dispatched to. So also, we get a lot of questions about, is the STAR team safe? Are the clinicians safe? Are the paramedics safe? And I think it's just kind of important to remember that these are situations that social workers would be dealing with anyway. As a case manager, on an ACT team, on, a homeless outreach team, this is really our population and where we work. So there's really not a big difference responding to it through the 911 system versus, how I used to go out as a case manager and deliver groceries or deal with crises in the community. So that's something else that I think is important to highlight that we've learned through STAR, and again, just to emphasize that we haven't needed law enforcement backup on any of those calls at all, which we're very, very proud of. We also quickly learned that we needed to meet more needs in the community than just behavioral health needs or low-level medical needs. So, much like Ann said, you may need sweatpants, you may need shoes. We have food on the van, water, harm reduction supplies, safe injection supplies, syringe disposal, condoms, socks, hand warmers in the winter, just really whatever we can use to build rapport and meet that immediate need in the moment. And it's been super useful, and we're able to stock all those supplies, and it's been really helpful. And also the paramedic component is just something that we've learned is really valuable. They're doing wound care. They are triaging low-level medical needs and saying, hey, you can follow up with your primary care provider. Can we help get you connected with one if you don't have one? Can we reroute you to urgent care as opposed to the emergency room because you don't actually need, emergency medical care? So those are just some of the things we've learned. Again, like Ann, I could go on and on.
Well, but thank you. I mean, that perspective is so important, particularly the question about, are you safe as the responders? I hear that a lot, and so it's great to have some direct experience to be able to speak to that. Ann, I'm going to turn back to you just to further explain a little bit about what you think the aspects of your program that have really contributed to its success, and are there similarities or differences with what we've heard from Carly?
Well, yeah, I think Carly and I both come from a very client-centered driven programming. And so, you can't say the rules for my team are, unless it's illegal or unethical, we're going to get to yes. And yes is fried chicken. Yes is cigarettes. Yes is broken down wheelchairs. And so what we found as well is in Washington State, we can't pair an EMT with a community responder. All the EMTs work underneath the fire and rescue umbrella. But we partnered with our local hospital and we're pairing an RN with our crew team. So you really do need that medical component. So many of our folks that are houseless, or the folks that we see, are not getting great treatment at the ERs. And so it's the number one place we drive people to is the ER. We drive people to encampments and to service providers, but it's still constantly going to the ER. So how we can divert folks from the ER was we're going to bring the nurse to us and pair them with a crew team member, just like Carly is doing it with a paramedic. You know, for us, data collection was the hardest thing the first year. So we've been up and running for 2 years, since April of 2019. The first year we were horrible at data collection. There was a spreadsheet for me to tell city council about how many calls they went on and how they were getting dispatched, and it was wet and miserable and the team hated it. And then they were trying to put data into an electronic health record, which had nothing to do with the services that they were providing. It had nothing to do with talk to Brianna for 2 hours about her recent breakup and then helped her organize her clothes and then left. I mean, that's not going to go into an electronic health record. So we recently, a year ago, had our city develop what we call the Collector app. And it's super useful for the team. They can look up clients. We can tell how they've been dispatched. We can give information to council by dashboards. But that was one of our big stumbling blocks was data collection. Like Carly, safety was a big concern for folks that are not used to working with this population. So I'm never going to tell someone that they need to feel safe or they shouldn't feel fearful. I have a different fear meter than other people, but you hire the right people. You hire problem solvers, you hire patient people, you hire people with lived experience, or maybe they have family members with addiction or mental health or homelessness. And we have never had a priority assist for our crisis response unit, and we go to about 2,400 calls a year.
Thank you, Anne. You know, as a researcher, when you said about data, you know, my ears perked up because, you know, the truth is we do need to be able to measure and explain the successes, but also to determine and track what's working, what's not working, and be able to do that in real time. So the fact that you folks were able to come up with something that was workable in your community and allows you to provide that information to your stakeholders, I think is really critical. And so I would encourage other programs that are thinking about this to really take that into account as well. As you're working in the field and doing all of that work, I know it's hard to think through, oh, how are we going to record all of this and get all that data to collect? But we've been bugging police departments forever, so I'm going to bug our community responders just as much. But thank you so much for your perspective and your experiences. I'm going to actually turn it back over to our federal partners now. And Dr. Everett, I'm going to ask you, you know, reflecting on the conversation that you've heard today, especially with these examples from Denver and Olympia, what excites you the most about these community responder models? And what do you see as the key challenges that jurisdictions are going to have to address to really integrate the models into their crisis response system?
What really excites me in hearing the examples is the language and the stance, I guess you might say, that this is creating with people in distress in communities. It's not an us, them, it's not a those people or sort of pejorative language. It's a whole sort of language and way of interfacing that could change really the conversation and the outcome, so that we're more oriented toward the humanity of these individuals. Rather than containment or, you know, arrest or things like that. So I think that's for people with mental illness, that goes a long way with regards to stigma and helping. I love the vision of the heart on the shoulder for the outreach as a part of the uniform. So I think that's really important. And stigma has been such a longstanding problem in our field in general that is really important. And I love the partnership with law enforcement. We need our law enforcement. We want our law enforcement to be effective, but I love sort of the widening the range of response capacity that this gives to law enforcement. So I think that's brilliant. I do think that also, in my mind, that relates to one of the biggest challenges we anticipate, particularly as we sort of promote this to be expanded across more and more communities through these state processes, is the not in my backyard or sort of the not in my community style. That could never work here. We're not sending out, you know, social workers into the community because they're going to get hurt or, you know, that kind of stuff. And so I think, you know, having more and more experiences that are successful that can describe themselves well is really important. And these two programs really, and the program that's in Baton Rouge, really demonstrate that very effectively. So that's very exciting. It's a challenge, but very exciting.
Yeah, I can't wait to learn more about these models. And of course, the researcher in me, we need to evaluate, we need robust evaluations and make sure that there aren't unintended consequences, right? We need to make sure and to figure out if there are unintended consequences, what they look like. Now, we know we've been doing that type of work with law enforcement for a long time. And so we need to just, as a research community, reach out to these innovative approaches and really start to document what's working. So I appreciate your comments. Director Mahoney, same question to you. What excites you the most about what you've learned today? And what do you see as some of the most important challenges that we're going to have to address to make these models successful?
Thanks. Well, I love hearing from the field. I miss the field. I miss being able to hang out with you all and ride with you and see you actively problem solve and support people, but it was good to hear you. So I'm excited about the prospect of the additional investments that we're making in this type of approach. I am excited about the potential for evaluation as well. I think that the only way that you can sustain this type of work is to show that you have the results and have third parties come up and say, no, this works. We need to do more of this. I've sadly been involved in far too many programs that have not been sustained, that everybody at this golden hour of time were getting along beautifully and it just happened and it was great and everyone knew what we were supposed to be doing and calls were being taken and you know, problems were being solved. But then somebody gets a new job or you get a new mayor or something happens and you get one generation away from that work, 2 generations away from that work, 3 generations away from that work. People don't even remember why they did it that way anymore. And I think that is the biggest challenge, but it's the most exciting thing too, that as you build this out, we've always known that a collaborative problem-solving model works. And now you're getting very specific about things that should be done and things that you think work. But what happens 3 generations away when you don't have the funding for it anymore and you don't have the people like you guys that are so passionate about this? So I think I'm most excited to invest in sustainment strategies. I know you're just starting, but I'm already thinking about sustaining. So sustainment strategies, and that's based on having good data and having good third-party partners that are saying, yeah, you're doing this right, and this is the way we should go. So I see it as a new frontier in a way, but I can tell you, I remember the day that the governor in Maryland gave us 9 social workers, 1 for each of our districts. And, no one had any idea what to do. Somebody just thought it was a good idea. And so they just threw these social workers at the districts. They gave them offices. And they did what, amazing public service, trained social workers do. They went out looking for problems and they started becoming the place where, police come across so many impossible scenarios all the time. And these social workers in these police districts became like the go-to place. They would just be like, hey, I think I saw this kid, I was driving by, I don't really know what to do. Police don't go to school on the child welfare system. That's not necessarily part of their training. They don't go to school on addiction. They hear about it a little bit, but they see these problems and they know that they're not in their wheelhouse. They know that they don't have the tools to solve the problem. And having that social worker just sitting in the office became this, like, everybody was just lined up. It was like Lucy, here, give her a nickel and she'll give you all of the assistance that you could want. it was really great. And so that was before we started thinking about different calls. That was just introducing the two professions to each other to breed that familiarity. And then like one day they disappeared. They just ran out of money for them, and they just went back, and it went away. And that's why I'm so excited about this program, because we're not going to let that happen to this kind of work. We're going to figure out how to keep this sustained and keep this cadence going and keep growing this idea so that it just doesn't disappear someday. So that's what I'm most excited about.
Great. Well, you know, in order to have that sustainability, I think we need to give some serious thought about our hiring and training and retention strategies that need to be adopted to make sure that we have the right people that are involved in this work. I know in the law enforcement field, of course, right now, we're really struggling with retention, hiring, and training for law enforcement executives or law enforcement officers. And so I'm concerned about what that looks like for community responders. And so I'm going to turn it back to Ann and to Carly after that to talk just a little bit about what makes someone effective as a community responder. How do you recruit and train that person? What does that look like in your community? And have you had success with retention, or are there issues and burnout?
I love this question. This is my new soapbox question, hiring. So we initially contracted for our services back in 2018 through just through this last March. And pay equity is a big thing for me. So if my folks on the crew team are working with the same folks that law enforcement would be engaging with, or the same folks that fire would be engaging with, or the same folks that the jail would be engaging with, they need to have an equitable wage. So the crew team came on as city employees this year because of that wage equity. They got an incredible bump in pay. I still have 5 out of the original 6 crew team members that started back in 2018. Consistency in staff and trust is huge with law enforcement. Law enforcement needs to know that when they call and request the crew team, that it's going to be Buck and Charlie, or Abby and Anna, or Teal and, whoever. And so we put them on a patrol schedule, which is what the crew team wanted. Our clients love having the same folks responding. So pay equity is a really big deal for me. I'm hiring and expanding right now. And we as a city I don't receive, as the hiring manager, names, cover letters, or resumes. I give them 10 supplemental questions. I want to know, how do you work with marginalized people? Do you want to stand outside 12 months out of the year? I give folks scenarios during interviews that are real life scenarios that our crew team responds to. But yes, no, I get really prickly about folks and peers. I love peers. I hire peers, but the box of a peer is so small, and the ceiling for pay is so low. And so sometimes I wonder if folks are hiring peers because they're cheap, or they're hiring peers because they believe in peers. And so for me, we have elevated, like Karis was saying, our peers into outreach specialists, because their incarceration is a part of who they are, but it is not everything that they are. And so hiring the right people and paying them equitable wages is how you have sustainable, in my mind, I don't have director in front of me, but in my mind, how you have sustainable programs.
Great, thank you. Carly, do you have similar perspective, or something additional that you folks are working on?
Yeah, I mean, I think, looking at our co-responder team, we have, next to no turnover on that team of 32 clinicians. Again, I would echo what Ann said, that it's really important for the PD to know and trust who they're working with. And I think that also that long-standing trust with the co-responder program also paved the way for STAR to be really successful as a pilot program. They already know who we are. They already know the kind of work that we do. They recognize us when we show up on scene, and that really helped. And I think when you're looking at a community responder, you really need someone who is flexible, who can think on their feet, who is not afraid to go outside of the box. That's huge to me when I'm hiring for my team. You can't get stuck inside your clinical box and be afraid to sort of step out of the realm of, whatever we consider normal to solve a problem. You just have to do what makes sense in the moment. And I also think that coming from a knowledge of community resources or a case management background is incredibly helpful, just because you can hit the ground running as far as problem solving and what resources to connect people to as well. So that's really what we focus on when hiring for our teams, and what we will focus on if we look at STAR expansion here in the near future.
Right. I've heard some law enforcement folks who have said things like, this type of community responder model is great during the 9 to 5 workday, but they're not going to respond in the middle of the night. Who's coming when there's a crisis that's off hours, or when they really need an immediate and fast response? What's your response to those folks who have that kind of perspective?
Yeah, I think it's a unique individual who wants to work as a social worker in crisis response and work alongside the PD. Our co-responder program just expanded into overnights and night shifts. So, there absolutely will be someone who will show up in the middle of the night or who will show up, without police cover. That's just what we do. I think a lot of these questions and concerns come from not having a true understanding of the work that social workers really do in the community. Just historically, we're driving people in our personal vehicles. We're bringing people groceries. We're, buying a chicken sandwich, like Ann said, it's just whatever works, or cigarettes. That rings so true. So yeah, I think, that if different departments and communities across the country would just sort of have a meeting of the mind between PDs and social workers, you'd find that you probably have a lot more in common than you think.
Great. Well, thank you. Those were all of our prepared questions for today, but we're going to turn it over now to the audience to be submitting questions. And these are being fielded to me and being sent to me in the chat function. Some of these questions came in ahead of time. Some are live. And so I'm going to do my best to weed through some of these and get some additional information. Some of the ones that are coming in, the biggest concern, again, is how are you addressing safety? And we've been talking about that a little bit, but there's an interesting perspective of what do you do with the people that the police see over and over again. So those are the, our frequent responders or callers to the 911 system. Do you have something specific that you're addressing for those repeat individuals in crisis? So we'll send it first to Carly and then turn it back to Ann from perspectives from the field.
Yeah, we absolutely, try to problem solve for those individuals that are just consistently popping up on the 911 system or having contact with police. I think the first thing we try to do is build rapport, right? We try to build a relationship with that person so that we can meet them where they're at, hear their needs, and really figure out what the drivers of that consistent police contact are. Then we're looking at what community resources we can connect people to, what unmet needs, are kind of contributing to this person consistently having police contact. Is it because they're unhoused? Is it because, they don't have a private place to change clothes, so they're doing it outside? Just a number of things can lead to this police contact, and just sort of getting creative and meeting those needs. Do you need to be connected to a day shelter or housing resources? Are you symptomatic and unhoused and, having a big behavior, like Ann said, out in public and people are calling 911 on you? Do we need to connect you to ongoing mental health supports and resources and treatment? And really just having a wide network of community partners, other service providers that we can work with to make sure that the resources and supports that we're connecting people to are more appropriate from a treatment perspective, from a cultural perspective, and from a needs perspective.
Anne, your thoughts?
Yeah, I echo what Carly said. We actually have a program that we started the year we started CREW called Familiar Faces, because really we do have, every community has folks that law enforcement are responding to over and over and over again. And I used to call them system resistant, but I now know that they are system failed. The system has failed them. And that is why law enforcement is coming into contact with them over and over and over again. So even our CREW team, we see a lot of the same folks. We do the best that we can. Like someday it might be substance use is why we're making contact with a familiar face. And then the next day it could be poverty. But really it is building that rapport, building that trust. And then we are like case managers as well, because honestly, we want solutions that last, not just solutions that work in the moment. So we do refer folks to our Familiar Faces program, which have what I lovingly call permanent supportive people. We need to have permanent supportive housing, and we need to have permanent supportive people for people in our community.
Great, well, thank you. And so that kind of leads me to my next question, which is, what does success look like in your both with CREW and with STAR? Because when people think about, well, you want to reduce the repeat calls for service, right, for police, and funnel those calls someplace else, but you also want to encourage people to call and to use your services. So is success a reduction in calls? Is it an increase in calls for your service? What does that, how would you define success? We'll kick it to Anne first and then back to Carly.
It's that data mind of yours that you want to measure outcomes and success. And I love, I'm just kidding you.
Came in as a question too.
I know, I'm just kidding. For me, is I have to put my success, it's an infinite game, obviously, with finite blah, blah, blah. But is the PD better off? Is the client better off? And is the community better off? And sometimes it's going to be the client's better off, and they're having the best day of their life in downtown Olympia until we can kind of corral them. Some days it's the PDs, so that's my matrix for success. Am I doing right by the police department? Am I doing right by the client? And am I doing right by the community?
Great, perfect. Carly, would you like to add?
Yeah, I mean, I would absolutely agree with everything Anne just said, and I'm kind of reminded of a meme I've seen and I use in some of my classes is, this is what people think success looks like, and it's a straight line, and this is what success really looks like, and it's, a huge squiggle going a bunch of different ways. Success can look really different, even on a day-to-day perspective, but I agree. Is the community better off? Is the client better off? Is the PD better off? Success also can be as small as police requesting us on scene, and I show up and it's someone that I know from when I was a case manager, and I know their name, and they smile when they see me, and they're happy to have a STAR response and feel comfortable and supported, right? All the way up to getting someone connected with permanent housing, which is of course like a big win. You have to adjust, I think, your definition of success call to call, day to day.
Well, that means that us researchers have to adjust our definition and measure of what those outcomes should be, right? We need to be looking more qualitatively and holistically about the health of a community and the health of individuals. So thank you both for those comments. We also have some questions about funding, and so I'm going to kick to both of our federal partners, but also to Anne and Carly as well. There were some questions about how you are funding this. Are you using local resources? Are there better opportunities to get state and federal resources? What does that look like for long-term funding? So why don't we start maybe with Kristen and Anita, and then we'll go back to our locals. Director Mahoney?
Just had to get myself off mute. Okay. We have our large justice and mental health collaboration program, JMHCP. But this year, because we're so invested intellectually and operationally in this approach, we have carved out funding specifically for this approach, and we call it Protect and Connect. And this will provide funding directly for social workers and community-based personnel to work directly with law enforcement in these initiatives. So those are posted on our website now. So everyone should check out the Bureau of Justice Assistance website, or look at grants.gov for Bureau of Justice Assistance. Those are competitive programs. I also wanted to suggest another measure of success when I was hearing Ann and Carly talk, and it reminded me of when we had so much pushback initially from law enforcement when we were installing closed-circuit television cameras in the neighborhoods in Baltimore. They thought that they didn't do anything, and they thought that they, were just gonna, be a waste of money, and they'd rather just have the money go towards their salary or more cops. And after we took the time, kind of like what you guys are talking about, took the time to explain the role, explain the responsibilities, because that's job number one for law enforcement, is accountability, that they're responsible, and to really show that you're sharing that responsibility with them, and that of course you can be relied on. Once you kind of get past all of that and have those tough conversations, the next thing I know, I would be out with police officers and they would be pointing to lampposts and be like, well, there's not one there, and there's not one there. So they went from, why are you putting them up, to, hey, I think you missed a lamppost. And so that's the trick with law enforcement, in my opinion, is that, you just have to be successful, you have to understand that they're responsible, they're accountable, and that you're not looking to take that away from them, that you're not going to, not be there for them. And this is going to support and enhance the entire problem-solving process. So once, Ann, you don't show up for work, or Carly, you don't show up for work one day and they go bananas, that's your measure of success. That they're like, what happened to them? Where did they go? I think that's probably the biggest measure of success. But please look at our solicitations. They are made to order just for this type of work. The timing of this event couldn't be better. So, use all of your resources to please, get the notices out to folks to apply for these funds. Thank you.
Thank you. And so, Dr. Everett, funding opportunities, and then we're going to turn it back off to Alicia or Aisha to close us out for the day.
Yeah. So, I think a lot of this is, when I think about federal, state, and local government, a lot of this is going to be some combination of all of those things. And the programs that we heard described today are based on what, primarily on local tax, sort of taxes and or funding from the police department. But there are, one of the other ideas of things that we're looking at is we're hoping that with the 988 we'll be receiving quite a bit of money to sort of work on the phone component of that, to support that, so that's stronger nationally and available. And then some of the first responders may be able to be structured into billing for Medicaid, Medicare, and or commercial insurance billing, depending on how they're set up. And the same with the crisis receiving centers. If diagnosis is rendered and treatment is given, then that may also be billable. So that's another large component that many states have sort of addressed already that way. But those are things that we're also looking at, developing models for.
Great. Well, thank you. And so, Aisha, I'm going to invite you back in from our friends from Council of State Government for putting this together, and to wrap us all up. We didn't get to all of those questions, of course, but Carly and Ann in particular have, put themselves out there to keep going with the conversation. And so thank you to all the panelists today. Aisha, turning it back to you. Thank you for hosting us.
Thank you so much, Robin. Thank you so much to all the panelists and to our speakers. And to everyone who's joined us today, as you just heard, we're really excited to continue this conversation. There's lots of other questions that we want to be able to help you think through and answer. So please do sign up for the upcoming fall convening from October 20th to 21st. And you'll also get notifications for all the intervening events and resources that will come out between now and then. You should be seeing a link in the comments box, so you can click that and go ahead and register. And just so you are aware, there are multiple ways to participate in that October conference. The first is, as an individual, you can come, you can learn from communities across the country and learn about innovations in community responder programs, as well as crisis systems more broadly. And second, though, if you're part of a team that's currently planning to launch or is working to expand an existing community responder program, we actually really encourage you to apply together as a team. You'll have the exact same access as individual registrants for the conference, but in addition, you'll also have access to one-on-one expert coaching, connection to peer sites, all of that to really support your efforts both during the convening and afterwards. Registration is free. It's open to anyone who's interested. So please visit the conference website to learn more. And just a huge thank you to everyone. And then just finally, we ask that you kindly complete a quick survey to let us know what you thought about this event. And there should also be a link in the chat for you. Take care, everyone. Have a good rest of your day. And we look forward to continuing this learning and continuing this dialogue with you.